بسم الله الرحمن الرحيم. يعني أنا so happy إن أنا أجوين الدريم تيم إن شاء الله في اللانج ترانسبلانت ويعني بالدعم المستمر لأستاذنا الفاضل الأستاذ دكتور محمود المتيني، وبشكر الأورجنايزنج كوميتي على المؤتمر يعني الناجح إن شاء الله. أنا هتكلم in short كده على ال post operative management and role of multidisciplinary post operative care in living donor living transplant. Lung transplant has evolved as a gold standard for selected patients with lung disease since 1983 by James Hardy in the United States. Patients with lung cancer, and he died within 25 days after transplant. And the number of lung transplantation is progressively increased worldwide to reach about 4,000 annually. And regardless this maximum amount of number of patients all over the world, we have no data or evidence-based data regarding the management, either intraoperative or post-operative management of those patients. Only we have a clinical trial and expert opinion. So the expansion of lung transplant provides a new challenge for us and for all the team of lung transplant. And optimally, to achieve an early outcome, that we have to be well-coordinated multidisciplinary team. The improved outcome evolved from a good perioperative critical care for these patients, anesthetic technique, surgical technique, perioperative use, and the optimal time and duration of ECMO, perioperative nutrition and physiotherapy for those miserable patients, pre and post-transplant surveillance for the colonization and infection, understanding the transplant immunology, and the improved immunosuppressive therapy. As we all know that prevention is better than cure, but post-operative acute critical care complications post-transplant are many. And we have two donors and recipients. So we have complications in 3 patients. So regarding respiratory failure, which might occur in due to primary graft dysfunction, acute rejection, up to pulmonary embolism, phrenic nerve injury, or hemothorax. Also the shock stage, either hemorrhagic shock stage, distributive shock stage, or the cardiogenic and obstructive shock. The most important complication post-transplant, the management of mechanical ventilation post-transplant, as we are dealing with 2 lungs by 2 different volumes. So we have to go for early protective lung strategy, early weaning within 3 to maximum 5 days. In other centers, we can go up to 7 days mechanical ventilation, but in our protocol, we will go, inshallah, to wean the patients within 3 to 5 days maximally. An extubation, early extubation to minimize the ventilator-induced lung injury by shear stress forces and release of cytokines. Initial ventilator setting, we should keep in mind that we are dealing with the donor lung, not the recipient lung. So we should know the protected body weight of the donor, and we calculate accordingly the tidal volume which be given during mechanical ventilation. Inspiratory pressure should be less than 28. We keep saturation SpO2 not more than 91% to avoid the complications of oxygen therapy and release of oxygen-free radicals. We will never use beep more than 10 to 12, and driving pressure, which is the difference between the plateau pressure and the peak inspiratory pressure, to be less than 40 centimeter water. And if the patient FbO2 FiO2 ratio more than 200, we will go for weaning. And if it's less than 200, we maintain sedation, and we go with initial ventilation setting less than 6 ml per kg. Adjust according to the ARDS network protocol, and respiratory rate to be less than 35, and we will go for percutaneous tracheostomy. And if the PO2 FiO2 ratio less than 150 or 100, we will maintain the patient on nitric oxide, and we will go for ECMO. Regarding the immunosuppression, As we said before, that acute rejection may affect up to 50% of the recipients in the first year of after transplants, and in the ICU will maintain the patients on triple drug therapy, as mentioned by dear colleague Hiba and Haitham. Induction therapy in patients at risk of renal dysfunction, we will go for paclitaxel and intraoperatively and day 4, and they might have a rescue dose in day 14 in selected patients. Regarding the hemodynamic, our target is to keep the lung dry and to maintain the adequate organ perfusion, which is maintained by the follow-up investigation, especially lactate urine output, to maintain urine output not less than 1 ml per kg per hour, mixed venous saturation using Swan-Ganz catheter to be not less than 65, and the lowest possible cardiac output to be not more than 2.2 liter per minute meter square. Regarding also the hemodynamics, Swan-Ganz catheter, we can keep it just to measure the left side function for maximum 48 hours and or more if we need to measure the left ventricular function. Mean arterial blood pressure to be not less than 75, central venous pressure, which is very crucial for those patients to avoid graft dysfunction and congestion, to be less than 7 millimeter mercury to keep dry lung, but to avoid the aggressive dehydration method to avoid the injury, kidney injury. One of the most important issue for those immunocompromised patients and all the immunocompromised, not only lung transplant patients, which are already doing an organ transplant, liver and renal transplant in our unit, is strict infection control measures. We will all respect these measures, and we have in our ICU a double isolation room with positive pressure. Donor and recipient, as we said, that we have donor and we should respect that we have 2 living donors. Donor and recipient pre-operative and post-operative infective risk factors, and donors bacterial or fungal infection before we should be detect before induction of anesthesia or selection of donor presence or absence of colonization. Recipient factors including the age and any other comorbidities. And the recipient factor post-operatively, the massive blood transfusion intraoperative, the prolonged ICU stay and prolonged mechanical ventilation so we will go and for early percutaneous tracheostomy and weaning from mechanical ventilation. As said before, that infection are the most frequent complication in those patients, and we will go for double antimicrobial therapy, piperacillin, tazobactam, and teicoplanin. The first day of admission for maximum for 7 days. Once the diagnosis, if there is infection confirmed by bronchial biopsy, bronchial aspirate, we will go for 14 days treatments by antimicrobial according to the culture, antifungal prophylaxis for 2 weeks, and antiviral for 3 months, and Septrim DS for 6 months. IVIG should be given in the intraoperatively, and we will continue for 5 to 10 days, especially if there is instance of critical illness myopathy. We can go for this dose for 10 days. Physiotherapy, which is a very important issue in those patients. Early mobilization chest physiotherapy before and after operation is a must, and the frequent bronchoscopy, chest percussion, and the high frequency chest wall oscillation may have important role for these patients. Nutritional intake, which will be discussed in detail by Professor Sarah, to maintain well and good caloric intake, and once the gut is functioning, we have to use the gut to avoid the complications of parenteral nutrition. Prevention of neurologic dysfunction, which might be a complication of the immunosuppressive drugs and complication of inadequate nutrition. So we will go for adequate sedation and pain control using dexmedetomidine, propofol, and fentanyl. Multimodal analgesia is a must for these patients. It will be started from intraoperatively by putting the paravertebral catheter. Early mobilization is a must for those patients. Early delirium screening, benzodiazepine will not be never given for those patients, and the complication of immunosuppressive drugs should be kept in mind. And in conclusion, we know that post-operative management of the lung is a big task for all of us. So we all know that it's not a one-man show, but it's a multidisciplinary team. And the increasing and complexity of the recipients and the lacking of knowledge in this field warrant continued research and clinical trial to further improve care of those miserable patients along their short and long-term outcome after transplant. Thank you.